Welcome everyone to the Dialogue McGill 2026 conference. It's a pleasure to see a lot of friendly faces that we know very well and some newcomers as well. So for today's session, you can see that we have live AI translation. Il y a une traduction pour la conférence et aussi il y a un QR code sur chaque table aussi. So it's possible to scan the QR code, and you can also have it on your phone if you would like. We would just ask that you keep your phone volume off so it's not disruptive during the conference, of course. But is the translation okay? C'est correct en français pour maintenant? Ouais? Okay, super. All right. We will have photography and filming of the full event. So especially for those of you who are on line of sight for the video camera, if you do not want to have the backs of your heads filmed, please, if you don't mind, just relocating to maybe a space off to the side. But I think it's high enough that you won't be in the film. But I would say if you're uncomfortable with having your photo taken or being videoed or anything like that, if you can just let a member of the Dialogue McGill team know, and we'll make sure that we don't use any of your photos or anything for our social media pages. So I'm excited. This is a big event for us. We've been doing a lot of planning. And we have some amazing speakers that Dr. Carmen Loiselle will introduce in a moment. First, I'd like to introduce our director and principal investigator of Dialogue McGill, Dr. Carmen Loiselle. So Dr. Carmen Loiselle has her PhD in nursing and psychology. She was an overachiever in graduate school. And she has it from the University of Wisconsin-Madison in the US. She is a full professor in McGill's Faculty of Medicine and Health Sciences. And she holds the Christine and Herschel Victor and Hope and Cope Endowed Chair in Psychosocial Oncology Research. She is also the Canadian representative of the International Psycho-Oncology Society and sits on the board of directors. She also serves as a board member of the Canadian Academy of Health Sciences. And in 2023, Dr. Carmen Loiselle and the Dialogue McGill team received over $20 million in Health Canada funding to be able to do different initiatives that enhance access to health and social services among the official language minority communities in Quebec, as well as to promote second language training, both in English and French, retention of health and social service professionals, and also research. So we do fund a lot of different research projects and initiatives, some of which you'll hear about today. Professor Loiselle's research focuses on the development, testing, and implementation of innovative interventions to best support individuals affected by cancer. So please give a warm round of applause for Dr. Loiselle. Thank you.
Ah oui, donc, je suis déjà branchée. Merci beaucoup. Merci, Jackie. Alors, Jacqueline Vachon, qui a un nom totalement francophone, vient des États-Unis et elle pratique son français, mais vous n'avez pas eu la chance de l'entendre, mais parlez-lui en français, elle adore parler. Donc, bienvenue à tous. Merci beaucoup d'être ici en grand nombre. C'est toujours plaisant de se rencontrer en personne plutôt que de façon virtuelle. Avant de commencer, j'aimerais qu'on reconnaisse qu'on est sur le territoire qui a longtemps servi de lieu de rencontre et d'échange entre les peuples autochtones, notamment les nations Haudenosaunee et Anishinaabe. Alors, Dialogue McGill tient à reconnaître et à remercier les peuples autochtones dont la présence marque ce territoire sur lequel nous sommes ensemble aujourd'hui. Alors, cette conférence a été rendue possible grâce à des fonds de Santé Canada et c'est pour soutenir toutes les initiatives visant à maintenir et à renforcer les capacités des professionnels de la santé bilingue et de la santé et des soins psychosociaux. Depuis 2004, Dialogue McGill et ses partenaires se concentrent sur les communautés du Québec afin d'offrir des formations linguistiques en anglais et en français, de recruter des étudiants dans les programmes d'études en sciences de la santé et en sciences psychosociales, et aussi de retenir ces diplômés prometteurs au Québec et de mener des recherches sur la meilleure façon d'augmenter l'accessibilité aux soins. Le thème de la conférence cette année est d'accroître la capacité et retenir les talents dans les services sociaux et les services de santé. Le discours d'ouverture, la table ronde et les présentations d'aujourd'hui porteront plus largement sur le recrutement et la rétention des professionnels à l'échelle nationale. Demain, nous nous concentrerons sur les défis et les acquis à l'échelle provinciale. Ce matin et cet après-midi, nous entendons parler des défis auxquels est confronté le système de santé canadien, ainsi que comment relever ces défis à l'aide de stratégies novatrices fondées sur des résultats probants. Alors, on veut aussi promouvoir des services de santé de haute qualité. Ce n'est pas toujours une mince affaire, comme notre conférencière d'ouverture le soulignera dans quelques instants. Dialogue McGill est honoré d'accueillir notre conférencière principale, la docteure Margot Burnell, qui est présidente de l'Association médicale canadienne. Je vais vous présenter Dr. Burnell. Alors, comme je disais, c'est actuellement la présidente. C'est une oncologue médicale qui a exercé au Nouveau-Brunswick depuis plus de 3 décennies. Elle est professeure agrégée de médecine à l'Université d'Alhousie et elle a dirigé le département d'oncologie depuis plus de 8 ans. Elle a également occupé le poste de chef du personnel de la zone 2 du réseau de la santé Horizon dans sa province. La Dr. Burnell a présidé plusieurs comités associés aux autorités sanitaires telles, les Sociétés médicales de Saint-John et du Nouveau-Brunswick, l'Association médicale canadienne, le Programme pan-canadien d'évaluation des médicaments oncologiques et l'Hospice Greater St. John. Elle a participé à de nombreux essais cliniques. Elle est coprésidente du Comité des soins du Groupe canadien d'essais cliniques sur le cancer. Et Dr. Burnell says that for her, being a physician is a calling. She remains eager to share her passion for medicine with co-workers and learners and believes in giving back to her community to make it stronger, healthier one. And please welcome Dr. Burnell.
Bonjour et merci de m'accueillir. Good morning and thank you to all of you for joining. Thank you to the organizing committee and to Dr. Loiselle for her kind introduction. My name is Margot Burnell. I'm a medical oncologist from New Brunswick and currently serving as president of the Canadian Medical Association. And at CMA, we're advocating for a better future for health, the health system, and health workforce. Training, recruiting, and retaining more medical professionals is, of course, a key part of this. And today, I would like to share where we're at, what's getting in the way, what works, what we can do together in Quebec and across Canada. So create our future for the health of Canadians. Before going deeper, I would like to acknowledge that we're meeting in Montreal, which is historically known as the gathering place for many First Nations who have a strong historic and ongoing presence here and are recognized as the custodian of the lands and the waters. Today, there is a vibrant urban Indigenous community here who represent many different nations from coast to coast to coast. And the request we make to the people of the host nations is that they bless our efforts here in the heart of their territory to become an inextinguishable light in the field of health and wellness. So where are we currently, and what does a normal day feel like for care providers right now? And I would like to share some insights into my own world. So as a medical oncologist, one who provides patient care, mentors medical students, and participates in clinical trial research, I have a fairly busy day. So as a physician on the team, I may see a new patient in consult, so a patient newly diagnosed with cancer. I hear their story, I review their medical facts, I listen to and acknowledge their fears and their concerns and understand the patient's goals. And then I develop a treatment plan and refer them to the additional supports, nurses, pharmacists, social workers, dietitians, among many. My next patient may be a lady receiving adjuvant or preventative breast cancer treatment who comes for her routine checkup and indicates that her partner of a long-standing relationship is thinking about leaving that relationship. So a very different conversation at that point. And my next patient may be a patient whose cancer has come back, and they're looking at palliative care, recognizing that their disease is no longer curable. So they have all of those emotions. They're scared, they're angry, they're fearful, and they're coming to us looking for compassion and hope. Throughout the day, I reviewed lab results, pathology reports, searching multiple different platforms that may be relevant to many of you in the room, received calls from patients, doctors, consultants. I enter systemic therapy in a computer system that at my place at best is described as cumbersome. I complete forms so that patients can access drug therapy. I fill out forms so patients can access compassionate care leave that their loved ones can access that and be with them during either their acute illness or end-of-life care. And fill out forms so that they can be off work. And so the challenges faced by physicians and their teams to provide the best care takes its toll. It takes time, it takes energy, and it takes emotional resilience. And by the end of Friday afternoon, I have nothing left in the gas tank, nothing to give, and so have to recharge over the weekend. Over this past year, I've had the privilege of talking to many physicians across the country, and my story is not unique. It's the story of many, if not most, Canadians, physicians. And what I'm hearing is the real concern, the concern about getting the care that the patients need, and about the unsustainable pressure on those of us working hard to provide it. And currently, the health system isn't able to provide the kind of care to which we aspire as professionals. Millions of people do not have access to a family doctor, to a nurse practitioner, to primary care teams. Others are waiting long times for tests or life-changing treatments. Lastly, we've seen politics enter into the delivery of healthcare within this province and other provinces. Governments entering into the patient-physician clinic room, and this is obviously disturbing. And here in Quebec, physicians were already stretched thin, morale was low, it was fragile, and then came Bill 2, a piece of legislation introduced without consultation, without collaboration, and without the voices of the very people who were asked to implement it. Introduced and passed in the middle of the night on a weekend. I was at the protest at the Bell Centre in the autumn, in the fall, standing shoulder to shoulder with clinicians who never thought they would be holding a placard or, so to speak, chanting in the streets. I heard anger, I heard frustration, but I heard heartbreak. I heard stories of physicians who were questioning whether they should stay in Quebec. They'd established their practices, they belonged to their communities, and their roots were here. But they didn't know if their future would be here. And so that is really difficult when Quebec needs all the doctors that they can get. And I heard appreciation for the CMA, that they were supporting them. And why was that? And it was because we were supporting the profession, our values, our training, our caring, our compassion, and our vision. And that is really that patients achieve their best possible health. So yes, in December, agreement in principle between the FMOQ and the government brought some relief, and it paused the most harmful parts of Bill 2. We're hopeful that the government will reach a similar constructive deal with the MFSQ soon to protect access to specialized care as well. But these moments are powerful. If we truly want to strengthen healthcare in this province, if we want to keep physicians here and caring for patients, we need dialogue, collaboration, and respect for clinical expertise. Nothing less will do. The FMOQ estimates a current shortage of more than 1,500 family physicians in Quebec. And according to the Quebec Statistics Institute, there were 9,900 vacant nursing positions as of 2023. At the national level, a recent report by Health Canada showed that we were short almost 25,000 family physicians, and Stats Canada, a shortage of around 20,000 nurses, 10,000 LPNs, and 21,000 registered nurses. So that's leaving many, many people without access to care, and is putting pressure on physicians, on all the other care providers to fill in that gap, and it's an enormous task. We know that countries with strong primary care, with upstream early intervention, do better across the board. Decreased morbidity, decreased mortality, and more satisfied patients. So would you rather have your blood pressure checked and treated in your family doctor's office, or find yourself in an emergency room or a hospital bed with a stroke? I think we probably would get 100% consensus in the family doctor's office. So these are really concerning trends. In oncology, my own field, many providers are reaching retirement age, while cancer incidence and prevalence are increasing. And unless we make changes now to expand the workforce, we will likely not be able to deal with the increasing demand for care. Every year, we're graduating more residents, and we're increasing the number of medical school seats, including with TMU's new program. However, we're still losing ground because physicians are retiring and more are choosing not to do comprehensive practice. And there is a problem with health workforce planning in Canada. It is totally siloed. Everyone is looking at their own profession in their own province, and they're not considering the fact that many physicians are retiring earlier. There are changes in demographics. Patients actually need more time and support from the teams, and there is an explosion of administrative burden. So speaking of the administrative load, it can be relentless, whether it's charting, third-party forms, sick notes, managing an office, or tracking down lab results. And 3 examples from my practice. The requirement for a prescription for a wig for a woman who's lost her hair due to chemotherapy must say wig, scalp prosthesis for chemo-induced alopecia. And if you don't have every line and every word, it gets sent back to you. I was recently completing a CPP form, Canada Pension form, for a young gentleman with advanced cancer who was constantly denied CPP and had to continue working despite being markedly unwell. I even consulted an individual in the know, and still he was denied until I put on the form actively dying, an unnecessary barrier to dying with dignity. And my 3rd example was advocating for a patient. He had glioblastoma multiforme, so the cancer that Gordon Downing had. He had an insurance form that provided benefits for life-threatening illnesses. But glioblastoma multiforme wasn't on that form, wasn't on that list. There were other malignancies who individuals that would actually have better survival, but this one wasn't. So I was on hold and hold and hold. I don't know if you've ever tried to talk to the medical director of an insurance company. You gotta wait a while. So, I finally talked to a lovely individual who totally understood what I was saying, totally agreed, but unfortunately couldn't change the written policy. But I hope that taking that time and that effort would allow him to go back and talk internally to invoke change going forward. So our recent report showed that 20 million hours of physician time is on unnecessary administrative burden. Another 20 million is on necessary administrative burden. The unnecessary converts to 9,000 family docs. And in many cases, this takes place after hours when we do our paperwork from 5 at night to 8 at night. Those times when we'd rather be having dinner with our family, running our children to activities, tucking our little ones into bed, that's when we're doing this. And so that does cause strain on work-life balance. And we would like to have that time back to spend with patients and their loved ones and for the real needs and concerns. I've come up with an acronym ideas. So innovate, integrate, delegate, eliminate, automate, and simplify and standardize. And I think those are many of the choices that we can make when going forward to address administrative burden. This isn't about paperwork, however. It's also about a system that steals precious time from providers and patients and fails to provide the very basics of integrated EMRs and support with administrative tasks. Next, many of us are really feeling the impact of health misinformation, disinformation, and false information. And it's creating gaps in vaccination coverage, fueling Canada's worst measles outbreak, and costing us our measles-free status. And we're feeling that every day in everyday interactions with our patients, and it causes a lot of grief and heartache. The US is also pushing on an anti-vaccine agenda, and skepticism about evidence-based medicine will daily grow and is growing. And this information affects patients because they start wondering who should they trust. And then when they don't know who to trust, then do they trust their providers? And so it erodes that trust between patients and physicians and forces us into really difficult conversations. Correcting that information and misinformation takes time. It takes being very calm. You need to make sure that the patient feels heard. And it's only when they feel heard can you start having that difficult conversation to understand what the barriers are to accepting some of the recommendations. And so this contributes to burnout, it contributes to emotional exhaustion, and many of us don't feel adequately equipped to handle them. So I would encourage each and every one of you to combat this in your social networks, place of work, defend the science, and support academia. All of this is having a profound effect on providers' health. And through the CMA's National Physician Health Survey released in 2025, 3,000 physicians responded, and we surveyed them, and we were looking on working conditions from professional experience and the broader medical culture. And that data showed that many doctors are struggling. 46% of respondents reported high levels of burnout. 21% had moderate to severe anxiety. 42% screened positive for depression, and 37% plan to reduce their clinical hours when we're already critically short. And we know that patients want change too. Our Care, which is a national conversation about the future of primary care from the perspective of patients and members of the public, undertaken by Dr. Kieran in Toronto, showed that 28% of people surveyed were satisfied with how primary care was working. And so really, we still have a lot of concern about that within our communities. Let me share one story that stayed with me. Dr. Alison McQueen, a family doctor from Calgary, loved her work and certainly had enough patients to keep her busy. But she saw a call for help from Newfoundland and Labrador, where a third of positions were left empty, unfilled, and she felt compelled to help. I can make a difference. What she didn't expect was the wall of red tape to secure her license there. 300 emails, 100 hours of paperwork. And at one point she says, I thought I was applying. In reality, I was applying to apply. She was losing clinical hours, and in her words, losing mental health hours. She persisted nonetheless, fortunate for Newfoundland Labrador. And when she arrived, she saw colleagues straining to keep up with the demand and patients in some of the worst conditions she'd seen, preventable suffering that had slipped through the cracks because there simply were not enough doctors to care for the community. When Canadians were surveyed last year, at a time with the upheaval of geopolitics, when sovereignty and economy were top of mind, 89% said better healthcare is key to a stronger country. Public health is a core Canadian value. It defines us as a society where no one is left behind, where we care for one another regardless of income, geography, gender, and ethnicity, and we lift each other up. Healthy communities are cornerstones to a healthy economy. Now, to the possibilities. I'm the eternal optimist, so always like to bring solutions to the table. So what can we do to make sure we're strengthening public health care for those who need it and for those of us who provide it? To recruit, retain those professionals in the system. And I'd like to walk you through some of the solutions that can make an immediate difference. So I've alluded to administrative burden and talked about it, so we'll delve into that a little more. When they're on the job, in their communities or elsewhere, physicians should be able to spend more time on the work that brings them the greatest pleasure and satisfaction, and that's interacting with patients and families. The CMA was instrumental in the passage of Bill 68 in Quebec, which reduces unnecessary paperwork, streamlines administrative processes across the health system, insurers, and employers. And that included reducing the need for sick notes for short-term illnesses. You know, by the time you get over your viral illness or you have a flare of a migraine, you get into your family doctor, it's 3 or 4 days later, and hopefully you're better. And so that was just causing undue strain, and more provinces have come on board, and we applaud that. We're also tackling disability tax credits. So this is a federal form. We've launched a 2-page simplified renewal form, which is being piloted and hopefully will be rolled out across the country. That initial form is 16 pages in length. And so we obviously want a shorter version, and we want a version where patients can say what their own reality is, what their lived experience is, and really self-attestation of where they're at. We're working with the federal government to drive digital innovation in health, investing in tools like AI, and hoping they reintroduce connected care legislation so that health information can flow among providers, and so that when a patient comes to see their physician or healthcare provider in the office, the patient can see all of their data and the physician can see all of their data. And so we know that 80% of care is provided in the community. So you have your chest pain, you go to the emergency department, you have blood work, you have ECG, you have an echo, you're referred to a cardiologist, you're on new medications, and then you're back in your family practice or primary care team, and if they don't know what's happened, and I'm there saying, are my medications okay? Can I go back to work? What might I hope for in the future? It's very disconnected. So this is to improve that and improve that system as we have it and make it more seamless and easier to navigate. Through the Healthcare Unburdened Grant Program, and this is funded by CMA, MD Financial Management, and Scotiabank, we're also providing support to other provinces to cut red tape. Technology in healthcare is moving faster than governments and health systems can keep up. And too often, new tools are rolled out without real input from the people who actually use them. So that's why the Quebec College of Family Physicians launched a structured consultative process with both groups. Kudos to them. Their goal is to develop clear, practical guidelines so policymakers, innovators, decisions, technology, and is developed with users, and make sure it genuinely supports primary care. We're also seeing the University of Sherbrooke unlock the power of patient-reported data. And this kind of information can make a big difference in how primary care clinics run, and it's still hugely underused. Their initiative will build the infrastructure needed to change that a digital platform to collect, analyze, and visualize patient-reported outcomes and experience data, and a learning environment to help clinicians use those insights to improve their practice. Along those lines, AI is already making a difference, and nearly 60% of doctors who are using it says that they're saving time. This may be auto-scribe, it may be billing, it may be scheduling, and it's giving them more time to spend with patients and improving their work-life balance. But to use AI well, we need clear, practical guidelines so clinicians can adopt it confidently and safely. AI can support knowledge acquisition and transfer throughout the healthcare continuum. The exponential growth in knowledge, personalized medicine is phenomenal. That's why the CMA is pushing for responsible, ethical, and sustainable AI, aligned with the World Health Organization, and why we've urged the federal government to build a framework that protects equity, patient well-being, and the integrity of the health system. Physicians are looking for legislation, regulation and accountability, liability coverage, risk management, and practice standards, similar to the approval of pharmaceutical agents or drugs. An important reminder, though, AI is a tool. It's not a replacement. It can reduce paperwork, but it can't replace trust, building relationships, and clinical judgment. I enjoy Dr. Lowe's quote from MIT, "Humans bring intuition, experience, and relationships. Machines, AI, bring speed, memory, and pattern recognition." The next important opportunity is to scale up team-based care models to provide access to care and reduce burnout in the medical professions. And this model recognizes that each member of the team should work to their scope of practice. They have clinical knowledge and expertise that they can bring to the table, and that patients benefit from that collective knowledge and experience of the team. So when nurses, nurse practitioners, physician assistants, and other health professionals can take on some of those aspects of care and relieve pressure on the individual and improve access for patients, then physicians are able to see those patients with the most urgent, complex, and concerning needs or concerns. In 2024 federal bilateral agreement, Quebec has committed to improving access to primary care by expanding family health teams, along with opening new frontline clinics and modernizing appointment systems. We're closely monitoring this work and recognize that access remains a big ongoing challenge. Supporting wellness keeps experienced doctors in the system and allows them to show up every day and do the work they like most, which is seeing patients, to bring their best to work each day. And the CMA has been leading the way on physician safety, starting with ongoing assessments of the state of the profession through our National Physician Health Survey, which I mentioned earlier. We're also developing a new policy on physician safety, which focuses on creating training and practice cultures that are safe, inclusive, and health promoting, and that actively protect people against harm. To further drive system change, we also bring together health leaders, researchers, policymakers, other partners, and possibly many of you in this room, to the Canadian and international conferences on physician health. Cultural safety and everyday kindness are so important, making sure people feel respected, understood, supported, so they can continue once again to bring their best to work. But we're unfortunately witnessing increasing incidents of bullying and harassment of our physicians and nurses. And in the National Physician Health Survey within the past year, 74% of physicians surveyed experienced it. In the Canadian Federation of Nurses Union survey within the past year, over 60% of nurses surveyed experienced it. and I suspect this probably underestimates the true number. The CMA has also made significant investments in physician wellness through our partnership with MD Financial Management and Scotiabank, and we've been able to fund wellness programs, and would like just to highlight WellDoc Alberta, a model that's now expanding across the country. WellDoc is known for helping physicians and healthcare organizations create healthier work environments, and not through quick fixes, but focus on system-level change. They give organizations the tools and structures they need to support wellness over time, including education, peer support teams, and training for supporters. And since launching in 2019, they've helped more than 7,000 participants. I look forward to seeing how their work continues to grow and can reach even more parts of the country. We've talked about the shortages in primary and specialist care across Canada, an issue we know we can't solve through training. We can't train ourselves out of this. And one of the ways is to close the gap is by bringing more internationally trained medical graduates and physicians into Canada, and to make it easier for them to start practicing and feeling welcomed in our country. In December, we supported new federal measures to fast-track immigration for international doctors through express entry and extra spots in the provincial nominee program. And these are positive steps, but we need to look forward to collaborating with government on further reforms, from immigration to regulatory assessments, employment pathways, and ongoing mentoring. We need a concierge-type service. One of the most inspiring examples I've seen how we can do this and better support internationally trained physicians didn't start in a clinic, it didn't start in a classroom, but it started at a Toronto coffee shop. And once a week for a year, a Canadian family physician, clinical research assistant, Dr. Eva Grunfeld, met with a Syrian obstetrician gynecologist to review medical English, words like forceps, placenta previa, so Faza could enter a midwifery bridging program and begin working in healthcare. Faza passed her exams, is now a practicing midwife in Milton, Ontario. I had the pleasure of meeting her a few weeks ago. And it is so rewarding to see these physicians come to a new country and integrate well into it. And Dr. Grunfeld went on to launch HELP, Health English Language Pro. So it's a volunteer-based language and communication program that has matched more than 100 newcomer physicians with Canadian mentors. And the program is boosting bilingualism in the medical community. So it's helping more physicians communicate with patients from diverse backgrounds, so care feels safer, clearer, and more culturally understood. This is really what meaningful integration looks like, and the CMA is proud to be collaborating and providing funding to the HELP program through the CMA Foundation. Another way to close gaps in care and better support new and current physicians is by expanding their mobility. Our goal as conveners is to simplify the licensure process so doctors can practice in any province once they are registered within their home province, with the appropriate safeguards to ensure there are no red flags. And this really goes a long way to providing better care. It allows the use of virtual care for people caring for people in the north, but needing consultants in the south. And it is a process that allows you to have a license. And this has been done in the Atlantic provinces, the Atlantic Registry. So I can register in New Brunswick, I can have a full license in the other 3 provinces without going through that cumbersome application process for each license. And the license fees are reduced for my non-primary practice areas. So the East Coast has done it, it's worked well. And we're hoping that other provinces will do this and that we will really have a pan-Canadian licensure, a multi-jurisdictional licensure, which could be used for physicians and having paved the way, hopefully then, for other nurses, allied health professionals. So we're really looking to discuss this and encourage this with integration and convening MCC and the federal medical regulators across Canada. Last but not least, we have to reduce health misinformation. And one of our goals is to make sure that it's reliable health system information that's accessible to everyone. So we know the people using it most often are in the younger generation. It's because they can't get access to primary care, and so they're going to social media. So we have to meet them where they are. And so CMA hosts Healthcare for Real, where we cover topics that are of interest to people going to social media in the younger generations. And we need them to get them on board and convert them and help them share the best information. And so once again, a call out for every one of you to participate. We conduct an annual tracking survey to help quantify misinformation problem and ensure decision makers truly understand what's going on. Our next survey will be released next week, so stay tuned, some interesting themes. And we also recognize the role that journalism plays in bringing credible voices to the forefront and translating complex science into clear, trustworthy stories. And we're proud to partner with the Canadian Press and the Canadian Journalism Foundation on these efforts. However, to accomplish any or all of these goals, 3 fundamental conditions must exist: safety, engagement, and accountability. With respect to safety, we need culturally and psychologically safe spaces to provide care and have difficult conversations. Listen deeply, be curious, share freely, and collaborate on solutions. With respect to engagement, physicians, nurse practitioners, nurses, allied health professionals face the daily realities of serving their patients, witnessing their hardships, their struggles, their successes, and appreciation. Seek out their solutions, suggestions, and thoughts. Seek out the patient voice, the lived experience. And finally, accountability. We must be accountable to ourselves and our profession to bring our best to work each day. We must be accountable to our patients and their loved ones to provide competent and compassionate care. And we must hold the system accountable to providing resources, practice standards, innovation, and the technology to fulfill our dreams and our patients' dreams. Healthy population, vibrant professions. So this is just a few of the ways we can strengthen the healthcare now and ensure Canada has a growing and thriving health workforce. You can visit cma.ca/r-focus to sign up for updates, to look at CMA's work in these areas and others. And the CMA is committed to partnering with like-minded individuals, many of you in this room, and organizations to move this work forward. So I welcome any and all feedback or questions that you would like to share. Thank you. Merci. Miigwech.
Suzanne Barwick, CEO Centre-Ouest out of the Jewish General Hospital. I have 2 questions. The first being students wanting to get into med school. You had discussed opening up the license across provinces, and you also discussed about foreign doctors coming here. Is there a plan to open up the med schools across the country so that, for example, UBC accepts 7 students outside of the province of BC? I know because my daughter is trying. Is there a plan to open that up so that we have more doctors coming up from the ground?
So there is a plan to expand more medical school seats across the country. Part of the problem is that they don't have the current infrastructure to do that in many instances with respect to classroom size. You also need enough teachers and mentors and physicians to provide care. You can have a lecture with 300 people in the room, but you can't take 300 people to a patient's bedside, obviously. And so you need to advocate for improvements in all of those areas. And so there's been a couple of new medical schools opened, a couple of new campuses opened, but it has to be done in a thoughtful way. I can't speak to how the provinces are looking at individuals applying from outside of the province, but understand the concern, because more people are moving around and changing of where they want to go based on lifestyle, partners, other job opportunities for their partners. So can certainly take that feedback.
Okay. My second question, sorry for monopolizing, was on connected care. Is there an aim to have the same connectivity across the country? For example, in Quebec, we have 2 connective care platforms. Is there something that is going to go across the country?
So the hope is that the integration of those systems and breaking down those silos will be improved. And so those various systems will be able and be required to share the patient journey, so that if you are in one part of Quebec that has one system and you end up needing care in a different part, that will be seamless.
Okay. Thank you.
Hi, my name is Carol Gravel. My question is regarding immigration of professionals, medical professionals, and even engineers and so on and so forth. About 20 years ago, I was working in Montreal. I'm in Lanaudière now with the English community organization of Lanaudière. Around 20 years ago, there's a lot of new immigration, people from other countries living in different areas in Montreal, notably Saint-Michel, Pineuf, Jean Talon. And what I had learned at the time when I was working in community organizations was a lot of medical doctors. They would immigrate. They would move here with their families, with their children, in the pursuit of a better life for their family. They were doctors in their own countries, engineers, teachers, and when they got here, they were flabbergasted to learn the difficulty with which they would have to work in their profession here. So you have to have all your diplomas and all that paperwork translated into French. And in the long run, and the outcome of this is that their studies were not recognized. Thank you. Not recognized. Of course, certain aspects of I understand certain aspects of the medical field. You were talking about terminology, the program with the mentors. I found that fantastic. Maybe certain practices are different, but they were told to go back to school, back to university to redo all their studies, which took a few years. They just moved here with their wife and their several children, and struggling to get an apartment. So in the long run, a lot of these people became taxi drivers. Their wives got jobs at Peerless, sewing, or house cleaning. So you come from a certain background where you have a certain status, okay, and pride. You end up a taxi driver. Your wife, culturally, it's kind of upside down for certain families. So what happens? Depression, conjugal violence, and meanwhile, the family's struggling. The children's integrate into French schools. They end up translating to the teachers and other people in commerces for the parents that don't speak French yet, or maybe English. So I just wanted to know this. I'm talking about 20 years ago. Today, have things changed?
So.
It's so discouraging. I'm advocating for the immigrant population here.
I think it's changed for many, and there are many solutions that are being put forward. So I'll just comment on a couple. So the first is that from the colleges that provide the licenses for doctors to practice within your province, they need to ensure themselves that it's competent and compassionate care. So across the provinces, they're identifying institutions that provide care and training that's very similar to Canadian standards, UK, Australia. For those programs that they do not understand as well, they're starting to look at them and understand those programs with respect to what's the training and what the standards are. Individuals coming to Canada and then having a license need to be assessed. And for those areas in those countries that do not have sort of an immediate licensure, there is a practice-ready assessment program. And that is where they are paired with a Canadian mentor. They have a practice, and they are basically observed while practicing. And that has worked really well. So a shout out to Nova Scotia, who has this practice assessment center for excellence and has really led the way to ensure that those individuals are assessed and deemed competent to provide care across our diverse communities and different cultures. And then they are integrated into those communities with a variety of licenses, full license or supervised license, and then ongoing mentorship. So we recognize the problem, we're advocating for change.
Thank you.
That's right.
So thank you so much, Dr. Burnell. That was very interesting, very stimulating.